This is Dr. Megen McBride. She is my new current physician. She's a naturopathic doctor. Maybe you can share a little bit about what that is, Dr. Megen, because I mean, I think people think that it's just somebody that's an expert in nutrition, which you are, but you also do go to medical school and you can prescribe and all of that. So I do want you to share a little bit about that. But I just want to tell you, I'm so impressed with Dr. Megen. I feel like my health has just skyrocketed since I've been working with her. I did a lot of work the previous year working on my gut, but so many things. She's just really been so insightful. And I really love to work with her because I feel like she's a partner in my health. And I think for those of you that are looking for a partner, she might be that person for you, depending on where you live, but maybe she can help mention the type of way to find a doctor if you're not in the area where she is in Southern California or in all of California, really.
Naturopathic doctor. It's a 4 to 5 year doctorate degree in primary medicine. It is considered a medical doctorate, so we're an NMD or a naturopathic medical doctor. I specialize in chronic disease, gastrointestinal, and hormones. So I do a lot of hormone therapy. I do a lot of chronic fatigue. I do a lot of gastro, like IBS, IBD, and autoimmunity as well. So quite a bit in the state of chronic health. I say if you need acute medicine, urgent care, that's not our forte in most spaces. But if you need that individual to help prevent and do primary care, that's where we really thrive and where we do our best. So
I wanted to talk today with you a little bit about just women's health, some of the things, and especially women's health in our age bracket. Our ladies, I would say our average age range is maybe 60. We've got ladies anywhere from 45 to even 85, but I would say the average age range maybe in the 60s. Some of us are like myself, just a little bit postmenopause. There's and looking at hormone therapy, but I want you to kind of get into a couple topics. Well, these three topics I think would be the top. One would be hormonal issues, hormone therapy, BHRT, as well as diet related to and how these all kind of incorporate insulin sensitivity and weight. And then thyroid, which I think we don't talk a lot about it, but oh my gosh.
yeah, I think medicine has really done a disservice when they've over compartmentalized or the cultural way in which our medicine is practiced in the States. They've over compartmentalized us. So the truth is that when a woman comes to me or a client comes to me and they're dealing with constipation or they're dealing with fatigue or chronic headaches, or just menopause or perimenopausal symptoms, I really want to talk with them and help them understand that it's affecting every aspect of their health and their well-being and every system of their body. It's affecting their nervous system, their muscular system, their joints, everything. So because in many ways it's not what do I take to fix this problem, and that's where we've kind of gotten ourselves into. I have a headache, therefore I take this, and it's like, no, that doesn't really work. But going back to BHRT, um, I love hormones. I am in it. I'm in it with you all. I'm in it with I mean, I'm a woman, right? So a woman will metamorph 5 times in her life. And as we go through these changes from childhood into adolescence and pre-puberty into puberty into reproductive years, and then we go into this perimenopause. Perimenopause for all women starts around the age of 35. Now, what that looks like for each of us is different, and depending on genetics, lifestyle, stress, all there's so many factors, diet and nutrition and all of this. But about 35 is when our hormones start coming down in the body, and they don't come down equally. And I tell a woman, hormones don't, just glide off like like you're coming down a hill. It's more like you jumped out of an airplane a little bit, and it does this, right? It's doing this. And there's multiple hormones. There's estrogen, progesterone, testosterone. There's other estrogens, just within the category of estrogen, there's multiple. So what's important to understand is that I think in our culture, and I say culture because it's really a paradigm of how you feel about your body, how you feel about your health. When you wake up and you say, I'm healthy, and I tell my children, not my children, well, I do tell my children, I do have children, but I tell my clients, health isn't necessarily a destination, right? It's a lifestyle. One day you're going to wake up and feel amazing. The next day you might wake up and feel fatigued or maybe some brain fog, but it doesn't mean you're unhealthy. It's not like you wake up and arrive at health. Health is little steps every single day. It's a lifestyle. And so that's important to understand because it allows us to go in and out of the shifts and changes in our life, in our week, in our seasons, as we come into holidays or family gatherings, and shifts, whether it's career shifts or just personal shifts in our lives, to be able to take those impacts and those changes with self-compassion, because the hormones are coming down. What's happening is that they don't all fall at the same rate, and the ovaries don't give up all at once, meaning the ovaries will continue to kind of build up, and then they'll release estrogen, or they'll release these hormones in kind of packets. And so we'll go through times of lows and highs. And I think what we think when we go into perimenopause or menopause is that we go from having some to having nothing. And that's not the case. So that's where I really feel like I can be of so much support for women, because when perimenopause can last anywhere from 2 to 15 years. So some women I know are going into menopause at the age of 40. Some women are 60 and still cycling. So it's really just so individual and dependent. The other thing I would say in the place of BHRT, research has shown that if you start hormone therapy within 5 years of menopause, and the menopause starts if you haven't had a cycle for 12 complete months. If you haven't had a cycle for 12 months, you are considered menopausal. If you have a cycle every 6 months, you're still considered perimenopause. So that's a big shift, right? Some people will have a cycle every other month, every 3 months, every 4, every 5, until they go that 12 months. Any bleeding after 12 months is considered breakthrough bleeding. It can happen with stress, or it can happen where you're bleeding and then there's stress and then there's no blood. Generally, that's what I find most common, is that stress can premature put us into perimenopause and all of that.
I have a couple questions, and one that actually came in. So I just want to reiterate, because I don't think you heard me say this. I always say on our coaching sessions that everything that we're talking about is for educational purposes only, and we're not giving medical advice. And that even though today you are a doctor, you are not their doctor, and therefore there is no patient-doctor relationship formed. This is not you giving advice, because some of the questions are very specific, and I know that you can maybe give ideas, but I'm sure you're going to suggest they need to seek out a doctor to have that conversation around. But okay, so let's say there's women here, they are not on bioidentical hormone replacement, and they're having sleep issues or weight issues, and maybe they've been postmenopause for over 5 years. Maybe they're past 60. There's kind of that two things past 5, within 10 years of menopause, I think was kind of that range of starting. And then they also have that category of after 60. And we've got a lot of people after 60, but we also have a lot of women that, oh my gosh, they struggle with sleep. So are they a candidate for, I'm just going to call it HRT. BHRT is hard to say. Are they a candidate for HRT, in generally speaking? Even so, will they have benefit? Can it help their sleep? Do they need progesterone and estrogen? What are those options that are available for them? And then I have a specific question, but I'll go ahead and go with that.
I mean, that sleep is one of the foundations of health, right? We talk about hydration, sleep, exercise, movement. I mean, this is foundational to our health and well-being. And unfortunately, it is one of the first hormones that we lose, as with any kind of stress and in perimenopause, is this progesterone. Progesterone is so impactful for calming the mind and calming the hamster wheel of thought and just overthinking. So that's so important, I find, for many women. And I want to say that I do often put women on hormones, on low dose hormones after 60, after 70, after 80 sometimes, especially when it comes in regards to sleep. Because sleep is crucial to healing, it's crucial to our mental health. We could go on and on.
Is that
Progesterone,
both progesterone and estrogen you're putting them on for the sleep, or just the progesterone usually?
I like to put them on both, and I'll tell you why. Estrogen is, I say estrogen just as it's a moisturizer in the body. It promotes the growth and development of the hormone receptors, and that means all of them. So if without estrogen, it's a little bit of a desert when it comes to hormone receptors, and those are the ability of the hormones to actually latch onto those receptors in the tissues and cause an effect. So if there's no amount of estrogen, you're not going to get the same amount of effect. So you have to go up on dose to get a similar effect, just to try to cause a little more saturation of those receptors and have the impact. The other thing with progesterone is that it's more impactful if you take it orally than if you take it topically for sleep. And this is because it goes in through the digestive tract, into the bloodstream, and through the liver, and the liver breaks it down into some components that help the brain rest and relax. Another thing, whereas if you put on topically, it goes into the lymphatic system. It's circulated through mainly the lymphatic system. It doesn't have the same brain effect but it does still have a calming effect, and it is very beneficial to get it topically. The other thing I find with menopausal women, um, is that we start to become insulin resistant. And this is very, very, very important. I wish I could just get my blowhorn and tell everybody, because what we find is that as we start gaining weight, as we start kind of going into carrying a little extra, part of the reason why we're doing that is because that estrogen is being broken down into different metabolic forms that are weaker. So when we're younger, we have really potent estradiol as the main estrogen. Um, when we go through perimenopause and menopause, the main estrogen for us is called estrone. It's a different chemical structure, and it's a weaker attachment to the receptors. What that means is that you need more to do less. And that can be really difficult, right? We're It's not that we don't have estrogen. It's just that the estrogen form is different and shifted. And that is difficult because the body then needs to hold more of it in the tissues and pull from it as needed for our mental health, for our, again, it's a moisturizer. We need estrogen. We all have estrogen our entire lives in some form, to varying degrees. But our body will store this in the fat cells, and it stores it there for our own health, so that it can pull out in times of stress, so it can pull out of the fat cells in times of leanness. That's a very natural thing that our body does. When you get a little more of the HRT, what we can do is give it in the form in which is a little more potent, but you have to scale it up, and you have to do it gently, because you have to create the receptors again that the body's used to having in order for them to be impactful. So I say for hormones, you need to have them or make them, whether you're making them, whether you're putting it in a patch cream or oral application. you need to use them. So you need to have the receptors for them to be useful, and then you need to get rid of them. And that will help to manage the weight, and it'll help the liver needs to be able to detoxify. We send hormone metabolic waste out in the urine and the stool, and so that those organs, those vital organs, needs to be working correctly. It sounds complicated, but it's a beautiful rhythm. Our bodies have done this our whole lives. It's just being able to give it the right messaging, at the right dosing in the right form, and then your body knows exactly what to do with that. But when I talked about insulin resistance, the thing about insulin resistance is that a lot of women will try to do these intermittent fasting, or they'll try to use tricks that they used in younger years to lose weight, such as, okay, I'm not going to eat after 5:30, 6:30. I'm turn everything off, and I'm going to be done. But what you really have to realize is that you're not battling the calories as much as you're battling the hormones, dysregulation, especially the adrenals, because the adrenals take over when the ovaries go to sleep. So as we go into menopause, your adrenals are now making your sex hormones. And those adrenals love consistency. They love calm. They don't like stress. So the truth is when we stress our body out by over exercising aerobically, or over exercising, or intermittent fasting to the point where we don't feed it like it actually will hold on to weight. It'll hold on to water, and it can inflame a little bit. So I tell my clients, if you eat a little bit of protein before you go to bed at night, within 30 minutes of sleep, it breaks every rule in our mind and in our historical what's healthy for us. But if you eat a little bit of protein, and I'm saying no sugar, no carbs, just a little bit of either animal protein from dinner, like just a little serving. I have a client who eats 10 pecans before she goes to bed. That's her. I have another client that eats half a Greek yogurt, unsweetened, natural Greek yogurt. One will eat half a string cheese, but she does dairy well. And this allows their blood sugar through the night to stay regulated, so you don't get that 3 a.m. wake up call, 2 to 3 a.m. wake up call that can cause lack of sleep. Because when you get that cortisol coming up high in the middle of the night, and then you just start thinking, and there's no progesterone on board to put you back to sleep. It's rough. It's very rough, and I have some women that get really interrupted sleep throughout the night.
Yeah, absolutely. I mean, I'm a perfect example of this because I had really low insulin levels for, I mean, a long time. And then post menopause, I started seeing all these changes. I'm like, why is my blood sugar so getting higher? Why is my morning fasting blood sugar in the 110s? And then it started going up to like 113. And I was like, it really scared me. And I had my levels checked, and my insulin levels had gone from like the twos up to the sixes. And I thought, I haven't done anything different. I'm working out, I'm eating, everything is the same. I had stopped intermittent fasting. A lot of you guys know I stopped intermittent fasting. I just intuitively knew it wasn't good for my body any longer. It was too much for my body. We talked about intermittent fasting in our book, so it worked for some people, but I always have said this, what was working for you at one time may not work for you in the future. So if you guys, a lot of you, have done our 30-day challenges and did the fasting and had great results with the fasting, well, just because that worked for you before doesn't mean it might work for you 5 years later. I mean, there's a change. So when I went on the hormones, that was the first thing I noticed is my insulin levels went back down to the twos from six. And that was only in a few months. And then my sleep, oh my gosh, my sleep, the progesterone. And I mean, I was getting okay sleep with the progesterone cream when I first started on the cream, but since I switched over to the pills, oh my gosh, I sleep like I don't get up to go to the bathroom in the morning. I'm like, ow, I have to go because my bladder is so full because I've slept through the night. And I'm sure that the estrogen affects the sleep too, but it was that progesterone. There's a couple questions coming in. This is one of those questions that I know that you can only give her so much information and it's not medical advice. But she had a stroke when she was 53. It was prior to menopause. She's never had any residual effects from the stroke. She's now 60, and her OBGYN said no hormone therapy for her and because of the stroke. And she wants to know, is this something that she should further investigate with another doctor to see if there's potential for her to get the benefits of hormone therapy?
Well, let me tell my own story. When I was pregnant with my fifth child, I had a small stroke in that time. I wasn't diabetic or had any risk factors that I was aware of at the time, but it did impact some of my. I have some small residual symptoms from this little stroke that I got during this pregnancy. Does it take HRT off the table for me? Absolutely not. I do think you should get another opinion. I think you should go talk with the doctors who are more up on their research. What's important to understand with heart attack, stroke, does HRT increase your risk? It does show within the first 6 months that your risk does initially slightly increase. So that is important to understand because estrogen can thicken the blood, testosterone can thicken the blood. And so what we need to be aware of and what we need to be mindful of is getting our blood work checked. The other thing is that we should all be taking what we call fibrinolytics. Fibrinolytics are enzymes that are very natural and capable of slightly thinning our blood a little bit because they break up microvascular clotting of the little tiny clots that get it kind of caught in the capillaries. Staying properly hydrated is another one. So if you've had any history of stroke, heart disease is another one, atherosclerosis, if that's a concern, then you should really be working with doctors that are forward thinking, that are preventative. Not the concern that I have so much in our medicine is that you're not sick enough yet to be of concern, right? So I get a lot of people in that middle zone where maybe they've had a past incident, maybe it was breast cancer, maybe it was a heart attack, maybe it was a stroke, and now they're or cancer of any kind, honestly, and now they're thinking of HRT. And what I say with them is, let's learn about your body. Let's learn about why this occurred in your life or why this has occurred for you biologically. Let's list those risk factors. Was it genetic? Was it lifestyle? And you can go through and kind of see someone's risk. And then even if you have no risk, the truth is we all should be doing certain things to support and prevent disease and support our health. And I there when clients say, what's the risk? What's the risk? I said, well, it's important in any medical decision you choose to say, what is the risk of me not acting? Okay, so what is the risk of me taking HRT? What is the risk of me not taking HRT? Well, the risk of not taking HRT could be women have the lion's share of memory loss or an early onset dementia. 85% of Alzheimer's are women. And this is in the XX brain. I cannot remember the name of the doctor that wrote it. She's an MD, big in HRT, but she reports, she goes, we get the lion's share of autoimmunity. And in our later years, as our hormones come down, we have bone density. Of course, we all are aware and the concern of osteoporosis. And so how do we keep our bone density? How do we keep our mind sharp and healthy? How do we keep our muscle mass, right? Muscle mass and brain are so closely aligned. So these are things that and cardiovascular health, these are the things that could be of benefit. So you just need to weigh the risks, weigh the option, and have a doctor that can help you learn about your own body and why.
Absolutely. I want to mention that I think one of the reasons that I first came to Dr. Megan was I ran into a gal in the gym and we were talking about HRT, and I felt like all of a sudden, I think I shared this all with you guys, that I mean, I was working out with weights so much, and all of a sudden my body was just so soft. I'm like, how is this possible that I am working out like with heavy, heavy weights and my body seems really soft? And so I wanted to look into getting back on testosterone because I had used it prior in perimenopause for some energy. And when I came in to see Dr. Megan, I'm like, do I have to take the estrogen? Because, you know, my mom had the DVTs. She had blood clots in her lungs because of the DVTs, deep vein thrombosis, blood clots. And so I was a little concerned about that. And I said, do I have to take the estrogen? She said, you do not have to. You can take just the testosterone. And so but she told me if you just take a little bit of estrogen, a small amount, it will help that testosterone. And so I'm like, okay, I'll go with a little dose, right? And she did give me that supplement, that enzyme that she was talking about that thins the blood, because she's like, I don't like how sticky your blood looks, even without all of this from just history. She was looking at some past blood work I had had. So then from there, I started doing all my own research. I'm like, give me more estrogen. Give me more estrogen. And I did have a recent test, and I want to have, I don't know, I probably should do it, I guess 3 months after, to test the stickiness of my blood and my fibrin,
Fibrinogen.
I have such a hard time saying that one, level. But so yeah, I have a little bit of risk in my background, not personally yet, but with my family history. So these are the types of things you want to talk to your doctor about, bring them up, have them look for. If they're not looking, like if you're seeing a doctor who put you on HRT and they're not testing your blood and testing your levels, somebody has a question on levels, you know, especially within that first, I think, year of starting, right? And then
Mhm.
regularly after that.
Well, we do, if you're cycling, we do get it on specific days of your cycle, which is day 21. Um, we do that so that we could capture the progesterone peak of your monthly cycle, so that we're looking at that relationship again between progesterone and estrogen, and making sure that in the first 2 weeks of a cycle, estrogen is dominant. In the second 2 weeks of the cycle, progesterone should be the main player and the main stage. And if that doesn't occur, it's more of a sign again that you're in this perimenopausal state where progesterone is low. So progesterone is usually a hormone that is prescribed first, and sometimes without anything else, just there. But if a woman is in menopause, and if she's been in menopause, well, and she hasn't cycled for 12 months, the truth is that her levels are probably, it doesn't matter when you necessarily pull the draw, because it's going to be low. It's going to be low enough that she's not cycling. So we just pull that draw, and see what the general levels are. And doctors will say, "Oh, you know, it doesn't mean anything. Hormones shift all the time." Da da da. Well, that is true when we're cycling, but when we're not cycling, we're not shifting so much, because what's taken over? The adrenals. So we're going to shift more in relationship to stress than we are in relationship to fertility. And that's what's helpful for me, because if someone's in the menopausal state, I say, yeah, let's get the test, let's see where you're at. And then we like to keep you in a range, between around 60 or 50 to 60, when we pull that estradiol, um, just to make sure you're getting enough, not to where you're going to get cycling again, though that does sometimes happen when you start HRT, that you might have some breakthrough bleeding just initially as the body's kind of getting those receptors going again. But it's just a way to keep those levels low and monitored. Yeah.
Along the same lines, if you have a mother that died from ovarian cancer, is this an issue?
It depends. So ovarian cancer runs in my family as well. Um, I had a grandmother pass away at 36 from ovarian cancer, and a lot of early hysterectomies in my family as well. Again, I think that it's just about doing the blood work and having a relationship with a medical provider that can teach you about your body. Um, because the fear used to be that all of these cancers, ovarian, breast, uterine, cervical, are all caused by hormone related, like genetics or hormones. But the truth is, it's 85% of of cancers of the sexual organs are not just sex hormone related, meaning it can be as much heavy metal toxicity, stress, and lifestyle as it, and, insulin resistance and insulin dysregulation in the body and our relationship with sugar and those kind of things. So if you have a family history of any type of cancer, ovarian, breast, it's the sooner you get integrative testing, and integrative means not the typical just CMP, which is liver, kidneys, electrolytes. Not the typical red blood cell, white blood cell. Those things are going to give you some good information about your vital organs and about your immune system. But you really need to pull autoimmune markers. Make sure that you don't have onset autoimmunity. Make sure that you pull those hormone levels. Insulin growth factors is a good one to pull. So you need to work with someone. You need to work with a preventative doctor to support that. As far as HRT goes, HRT has been shown to be very cancer protective, but you don't want to jump into the pool without understanding your body. I guess that's what I'm trying to say.
That's good. Thank you.
First of all, I did have the cancer history. I had malignant melanoma given 6 months to live. I'm 77 now, so obviously God chose to allow me to live. But because of the melanoma and because they thought it could possibly been hormonal at that time, I've always been afraid of that. And as a nurse and stuff, it would affect it more. So I really prayed about it. And when I quit and went into menopause, I tell you, it was overnight. I had my period, it's done, nothing, no hot flashes, nothing except sleep. I still do not sleep. And we're talking, I'm 71 now, and that probably happened in my early 40s.
Wow. Yeah, 30 years of lack of sleep is so difficult. My question for you with the melanoma and the cancer history, what are you doing now to support your health?
I I actually am working really, and I did functional medicine a year ago, but you know what? It ended up being, I kid you not, over almost $200 a month with the various things that we're doing. And
Mhm.
interesting enough, as I'm listening to you, nobody addressed hormones. They sent me to a sleep study, which turned out nothing. And I even said a couple times, is it hormones? So they were
Yeah.
so caught up in mold. But I have, the reason I went to functional medicine is I've developed a possible mast cell activation syndrome. So that's what sent me there. And I still react to chemicals now. I react to food now. So I'm actually going to switch to a new group to see. So that's where I'm at.
Are people candidates? Not necessarily. I know you can't. I'm not asking you to diagnose or treat or anything. So just clarify. I always like to put my little disclaimer out.
Mhm.
But a woman could, if try just progesterone for her sleep without estrogen. Or do you ever have any clients, or do you know of women that don't want to put that extra risk because of the estrogen cancer? Maybe they had a cancer that was estrogen positive and they
Mhm.
just don't want to take that risk. Can they do progesterone? Can it help them with their sleep?
Do prescribe progesterone for specifically for sleep without any estrogen. Um, Sometimes I'll prescribe estriol, which is a more of a cancer protective form of estrogen, E3, and so that's something that with someone with a real concern about cancer, um, they may do estriol, but you can definitely do progesterone on its own and see if it's impactful for sleep. You're Another thing is a little bit of testosterone might help as well, because testosterone does make a little bit of estrogen, or it converts. As testosterone is the precursor to estrogen, so
Right.
that can be helpful a little bit too. But definitely the progesterone, and then the neurotransmitters, making sure you're getting some H2P and GABA and your B vitamins and immune support, ashwagandha to support the hormone balance. And there's phytoestrogens. So there's phytoestrogens or estrogen that plants make. And so that would be like your yams, your flaxseed, dong quai, black cohosh. These are, you can go into this space that are very, and even soy can be very cancer protective. Anyways, we don't have to talk about the 90s study, but
Yeah, the study that came out in the 90s, the Women's Health Initiative, there was a lot
yes,
of skewed information that the media ran with was not. So there was a huge fear mongering that went on with it, which is not actually the information that came from the study. It was kind of blown out and made to be something that it wasn't exactly.
that's right.
Make a simple story on that. So we for how many years is that? 30 years? You know, it's like we've been robbed of what could potentially be helping us. And I was thinking about this the other day. My mom, who actually was on the Premarin horse urine, not bioidentical hormone, from when she had a hysterectomy in her 30s till like 77. Now she did have DVT. So they finally, and she had a stroke. They took her off of that, which was, I think, a smart move, but they didn't offer her an alternative at the time. And, but I have to say, she's now 83. So it's probably been 6 years since she's been off of it. She has no osteoporosis. She doesn't have really any heart disease. I had her do the CT calcium score because they wanted to put her on cholesterol. I'm like, no, her level was super, super low. Her brain is working really well. Yes, she forgets things. She doesn't, and if she had been exercising all this time, that with a cherry on top, she would have. I just feel like having that estrogen in her system has prevented a lot of health issues that she would have possibly run into. I think I know this, but maybe you can clarify. You can do telemedicine with people in other states, but you can only prescribe to people that are in California, correct?
I can only practice medicine in the state of California. I am considering licensing in Washington State as well. But I so if you're out of the state of California, I can do a health consult and be like a health coach, preventative, kind of guide you into how to talk with your doctors, how to, what I would do in your situation, but I can't prescribe outside the state of California. That's correct. But I can do telehealth, video conferencing on the phone, and then of course in person. But it's important, I think, to know your doctor and for your doctor to know you, and that's becoming harder and harder these days to find.
Let's talk about the estrogen cream, the vaginal estrogen cream, and why it's so important. I mean, a lot of women use it because they have painful intercourse. They want to help with that to bring the moisture. But let's talk about preventative for long-term, I guess, it's not, is it atrophy and how that can relate to, it could literally save somebody's life. And, if they get chronic UTIs, my mom gets them. I told her, she's 83. I said, you got to ask your doctor for vaginal estrogen, and it can still work
Yes.
now.
It's important to understand what estrogen does in the body. Estrogen can tighten and strengthen your ligaments and tendons. So, what's holding the bladder? What's suspending the bladder? What's suspending the colon and the intestinal tract? And the vaginal is that those ligaments and those tendons. So that pelvic floor is so important to keep that moisturized and strengthened, because without it, those the vaginal walls will start to relax, and you'll get what we call prolapse, which is where the bladder can come down, or the intestinal tract can come down and lean into that space for you. As the bladder comes down, then it's going to increase your risk of UTIs. And then as UTIs happen more frequently, it can create where the organisms are now kind of in the lining of the bladder, or can be, and the ureters in the bladder. So anyways, it can create into chronic cystitis and other issues. So a little bit of estrogen, even if it's estriol, just estriol, even if it's DHEA. DHEA is a precursor to estrogen, a precursor to progesterone, testosterone actually, and then estrogen. But they have found that it solves 85% of, I don't know why 85 is such an important percentage, but so many incontinence, urinary incontinence, and it can help with stool incontinence. Just a little bit of vaginal estrogen, because again, it's getting the strengthening and the toning of that area. That, I mean, I have clients that go to pelvic floor PT, physical therapy of the pelvic floor, and you can do that with strengthening of the muscles, but you can't strengthen a tendon and a ligament if it's dehydrating. But one thing I want to help people understand is, if your estrogen comes down, your cholesterol will go up. If your estrogen comes down, your insulin resistance will go up. It's not individual. It happens to all of us. The degree is individual. But that connection is solid, because estrogen moisturizes and it tonifies the body, and it's been moisturizing and tonifying your body since prepubescence, or not prepubescence, but since puberty. So what is cholesterol? But it's a moisturizer. So if you're dehydrating the tissues of the body, if you're dehydrating the cardiovascular system, the liver is going to make more cholesterol in order to add moisture to the body. The other thing that is important to understand is cholesterol is a precursor to all of your sex hormones. It is the first step in all of your steroid production. So even your stress hormones, your anti-inflammatory hormones, they all come from cholesterol. So in this menopausal state, your cholesterol is going to come up. In this menopausal state, your risk of diabetes is going to go up. And what they don't understand, I mean, how much money and how much effort is it going into controlling cholesterol and diabetes without any discussion for us women of a hormone replacement therapy? I'm like, it is such a disservice to us. And then if we do have the cancer risk, where is the discussion with, when our hormones come down, does it increase our cancer risk? To be honest with you, a lot of the wisdom of menopausal wisdom, meaning women talking to other women just feeling comfortable discussing aging together, it's coming back. These kind of forums are so powerful, so beautiful, because it allows us to ask these questions and to feel safe in not just asking the questions, but considering different options other than just a statin drug or an insulin manager. These kind of things, and especially in this group of women, you're not in this group because you're not health minded. You're mindful, which is why you're here. When I talk to someone like Robyn, who works so hard to be healthy, and then she comes to me and tells me, I'm working hard in the gym as I've ever worked and getting less results and this and that, I know hormones are the factor there. It's not mind over matter. This is just solid science. It's solid biology, and I'm just, if I could just, I'll get off my soapbox, but I really feel like, unfortunately, there's been a disservice for the last 3 decades, or really for the last 3 decades. It's just been this fear of it, and therefore all the symptoms are treated just enough, but prevention is really where we need to be, because yeah, it makes a big impact for us when we go into menopause.
I think it's really exciting for the next generations coming up that they will have, they can start and understand and get educated and have so much more prevention, but it's not too late for us. The other thing I wanted to mention is that a lot of people will go on the vaginal estrogen for the reasons we were talking about, and it is localized versus systemic. Is that true, that if you put the estrogen just down locally, that it does not necessarily go out throughout your whole system?
It does still regulate throughout the system. But what I would say this, because the pelvic floor is so full of blood, vascular, it's just
Mhm.
rich in vascular um, veins and arteries and all the things. But what I would say is it's all about the receptors. You're in the pelvic floor, you have a lot of sex hormone receptors because that's where your ovaries have been, right? So the bladder, the intestinal tract, the vaginal canal, these are areas more rich in receptors than the back
Mm.
of your thigh, right? The back of your calf or your shoulder. So when you apply it there, it's going to saturate those receptors first and be circulating through the body less than if you applied it. If you apply it, like some people, there's a lot of people put it like on the inner arm. I don't suggest putting estrogen on the inner arm. The only reason being is that for some women, their breast tissue is really rich in estrogen receptors, and they can get some fibroids or some discomfort in the breast if they're putting their estrogen too close to the breast. And then I just think that the pelvic floor, as far as moisturizing, as far as tonifying and all of that, is just the place to put estrogen. Whereas
Mhm.
progesterone, I put it on the upper half of the body. There's more progesterone receptors. So if you put progesterone as a cream, if you're taking it as a cream, on the abdomen, on the breast, on the arms, you're going to get more of a response there.
I've learned like there's just so many methods of delivery with the hormones. Like there's the compounded creams. There's what are they? The pellets that they inject. There's I just switched to the patch, which I'm loving because it's just easy. You just pop it on and go. And I was using the cream for my progesterone. Now I'm taking the pill, which I love that. But there's a lot of different delivery systems. And I know when I first started, and this is just something if any of you are considering starting, we Dr. Megan put me on some progesterone, a small dose of estrogen, and the testosterone. And I got it from a compounded pharmacy. And she's like, how do you want this? I said, because I'd done it before, I'm like, I want every one of those separate. I don't want them all compounded. It would have been in one formula. It would have been cheaper. But I said, starting out, I want it all separate so I can figure out the dose. And so if I did, and I was taking, I had to go back down on the estrogen because it was, things were waking up and I was like, they were waking up a little too much for me. I can't describe any of that. But so I had to pack down. So it was really nice to be able to swap around. That's why I like people with pellets. I don't recommend somebody jump out there and put pellets in because it's in for 3 months. And later, if you figure out how your dosage is working, you want to swap over to a pellet, that sounds great. But I always think, less, start with something that you can adjust and adapt to. One other thing, let's talk real quickly about some people have to go with the by mouth estradiol, but I've read that that is one that systemically um, has more potential side effects because it has to go through the liver, and I'm not exactly sure why.
So, it tends to be, from what I've found, is that on the East Coast, I don't know why it's East versus West, but on the East Coast, when I'd go through hormone trainings of doctors in that, New York, Boston, anyways, they really prefer oral estrogen, or they'll have women dissolve estrogen under the tongue to get it that way. There has been found to be more of a cardiovascular and brain benefit if you take it orally. And that's what they're citing. They're citing, this is more of a benefit. And frankly, it's just higher levels have shown to be protective against stroke and heart attack and dementia and all the things that we're talking about, and it can also be a little bit of a risk. Um, so that's interesting. Now I called a pharmacist here, and I just said, fresh off of a continuing education conference, said, how many of my peers, MDs and naturopaths, are prescribing oral estrogen? He goes, none. I said, are you sure that this is a big pharmacy that prescribes a lot of hormones? He said, it's very uncommon on the West Coast for doctors to prescribe that way. I said, well, why is that? And he said, well, because we're more fearful of the cancer risk. We're more fearful of the clotting risk. The East Coast is more fearful of the dementia, and they're more fearful of the heart attack. I said, well, clotting, heart attack. I mean, I'm kind of telling you the backside story in that different theologies, different research.
Mm.
The creams are applied, they go under the skin, and they're circulated primarily in the lymphatic system. Now, when you take topical hormones, it's important to get saliva and urine testing on occasion, just to make sure that you really know what the levels are in the lymphatic system. Whereas if you're taking it orally, then they're pulling blood samples because of that pass through the liver. But it is a little more risky to take it orally. It's a little harder on their liver. Many women, and it's not just women, many individuals have a liver congestion, gallbladder issues, pancreas issues. And so when you're throwing these high dosing hormones through there, it can cause a little more of a risk. So like I said, you gotta get them in carefully. You gotta use them, and you gotta lose them. You don't want the body to store these metabolic waste of these hormones. That being said, the pellets, if I could just touch on that for a minute, I I have considered doing pellets, not for myself, but to train to be able to provide pellets for my clients. And the companies that are providing pellets are high dosing these hormones out, especially the testosterone. So I see a lot of women, their testosterone will go up to 500. Our testosterone is usually between 20 and 40. Like if I see a bodybuilder, a female bodybuilder in the prime of her, like 29, 30, 31 years old, she may have a testosterone of 60, maybe 70 if she's supplementing with herbs and whatnot. So these women are coming in menopausal. I'm running their labs. They're at 500. They're wondering why they're losing their hair.
Mm.
It's not metabolically natural to do that, and yet these companies are just keep putting these in. And that was a woman who actually requested and waited for a half dose pellet. So when I talk to these pellet companies, because I reach out to them as well, and I say, why are you doing that? They go, well, just such a big result. They really feel it. They get the energy. They get all the benefits of this testosterone. I said, yeah, but it kind of throws them into some rage. It might, there's side effects. There's side effects of these hormones that we need to respect. That's why I really feel that dosing low, building up to what's good for you, giving your body a chance to waken back up and get the receptors going again, much safer than throwing a pellet in. Although I know more than one client that just loves their pellets, and I support them. I mean, it's not a problem. It's what works best for you is most important.
How much estradiol vaginally per week? Is it, do they do it once a week, twice a week? The other question is facial hair an issue with testosterone? I can answer the facial hair one. Because I'm taking testosterone, and I take saw palmettoberry, which helps block the DHT. It's the DHT testosterone, and Dr. Megan can give you I don't know, it's a long word, but that causes like acne and hair loss and. I do have a few extra, I always have a few extra whiskers right here. So I just pluck a few, but that helps definitely with the acne for sure. And I just take one capsule of that at night and it seems to be doing great. The vaginal estrogen, how often is that usually done?
The quickly with the testosterone, I can't help myself.
Go
The
ahead.
testosterone, you also want to take zinc. Zinc is huge as far as a blocker from that DHT. Saw palmetto is amazing, and I do highly recommend it. It is a phytotestosterone, so it's a plant that can can go onto the testosterone receptors. So when you're taking a testosterone, the supplemental will get onto and compete in those receptors, lessening the impact of what you're taking. So that helps so that you don't get all the side effects of the hair loss, the acne, the whiskers, or the hair on the body. Women in general, because testosterone is a precursor to estrogen, when we go into menopause, the adrenals are making that progesterone and the testosterone. And if that testosterone is not converting to estrogen, or if it's converting to DHT, that's why you're getting the menopausal whiskers. And so, super important to get your minerals, especially your zinc. Okay. Estradiol or estriol, when you're taking it vaginally, you need to get labs. You just got to get your labs. Everyone's a little different, and everyone genetically and lifestyle again has set them up for a little different package as far as absorption and rate. So giving one person a 1% estradiol or estriol vaginal gel, it is hard for me to predict. It's hard for me to predict how quickly the levels are going to go. I have example, 2 ladies, best friends, coming to me. They walk every day together and whatnot, and they're wanting to get on HRT, and I give them both a very similar dose. Their labs, both of their labs, 0. I mean, not a 0, undetectable amounts of estradiol and estrogen. So I start them both on the same dose, and one takes off, and now she's well into the green, and the other one is still 0. So it's very hard to predict as far as like dosing goes. That's when you have to get into the practice and the nuance. Once you start hormones, you want to get labs in 3 months. So you want to get like foundational labs, or maybe just get started. Wait 3 months. Give yourself 2 6-week cycles for your tissues, the tendons and the ligaments to have 2-week healing cycles, or your cells are constantly replenishing. And then take those labs, see where you're at, adjust the dose accordingly. You can come down or up on the dose. And then if you settle on a dose and you're feeling good about that dose, then you should get your labs done every 6 months. Every 6 months, you just get your labs done. It checks for all the estrogens, total estrogen, progesterone, testosterone, DHEA. It tests for insulin growth factor, insulin, HbA1. Would just get your screening every 6 months. That will help you, give you peace of mind, and let you know that you're dosing correctly. Generally, I start on a 0.3% estriol or 0.05% estradiol vaginally. But that's not medical advice. That's just general information.
Well, thank you so much. I mean, this has just been a wealth of information. Like, I'm sure the questions could go on and on and on. You've just been fantastic. We're just so grateful that you came on to spend this over an hour with us answering all these questions. People are saying, thank you. Wow, such great information.
You're welcome. Thank you.
All right.
All the very best.
Thanks.